I'm John No. I'm a third-year medical resident here at Santa Barbara Cottage, and my topic is, does ECMO improve mortality in acute MI-complicating cardiogenic shock? So let's get started. What is ECMO? It's extracorporeal membrane oxygenation, and of note, I'm going to use it synonymously with extracorporeal life support, because that's what our European colleagues call it. It's a temporary form of mechanical circulatory support that's used to treat adults and children with life-threatening cardiopulmonary failure. It was noted to be used first in 1953 by Dr. Gibbon, who is pictured there on the bottom right. And he used this concept of artificial oxygenation and perfusion during a successful open heart operation. And you could actually see this first machine in the American History Museum in DC. So just some numbers. Through 2020, 150,000 patients in total have received ECMO, 75,000 of them being the adults. Its usage was greatly increased, noted after the Caesar trial in 2009, and this was a trial that supported ECMO use in the setting of severe ARDS, and it was one of the first randomized trials that showed 180 patients with severe ARDS having significant outcomes in mortality and 6-month severe disability. But it was heavily debated, as only 76% of the ECMO group actually received ECMO, and the lack of the use of the ARDS-NET protocol for mechanical ventilation through the patients couldn't really show that if ECMO was better than the ARDS-NET protocol. Something of note as well is that there has been a small signal of some improved survival and neurological outcomes observed in certain patients receiving ECMO in cardiogenic shock, but this was in patients that had in-hospital cardiac arrest with minimal delay in initiation of VA ECMO. So the myth, would ECMO improve mortality in infarct-related cardiogenic shock? So there's two types of ECMO. There's VV ECMO or veno-venous. This provides respiratory support, pretty much drains the blood from the venous system. It's oxygenated and reinfused into the venous system, supporting gas exchange, but no direct cardiac support. And this is used in ARDS patients most commonly. There's also VA ECMO, which is veno-arterial. It bypasses the heart and lungs, and this is the choice in cardiogenic shock as well as refractory cardiac arrest. And you use either a peripheral or central cannula. You drain blood from the RA or the vena cava. You oxygenate it, and then you infuse it back into the femoral, axillary, or carotid artery. And in specifically cardiogenic shock, femoral access is preferred as it decreases ischemia to the ipsilateral lower extremity. So VA ECMO specifically, the circuit, like I explained before, and it's pictured here, you have a venous or an inflow drainage cannula. You have a pump, an oxygenator, and an arterial outflow return cannula. Its specific indications include low cardiac output, hypotension despite being on inotropic or intra-aortic balloon pump device support, cardiogenic shock, peri-procedural for any high-risk cardiac interventions, post-op heart failure, post-transplant in the setting of primary graft failure, or a bridge to long-term ventricular assist device support or heart transplant. Some contraindications, or absolute contraindications, are unwitnessed cardiac arrest, prolonged CPR without adequate tissue of perfusion, not a transplant or VAD support candidate, unrepaired aortic dissection, severe AR, disseminated malignancy, or lethal chromosomal abnormalities. And then the risks and complications include the cannulation itself, hemorrhage, dissection, distal ischemia, or incorrect location. And then you can also get cardiac thrombosis or coronal or cerebral hypoxia. So defining cardiogenic shock, per the Society of Critical Care of Medicine, it's defined as severe impairment of myocardial performance that results in diminished cardiac output, end organ hypoperfusion, and hypoxia. This is important as cardiogenic shock is the leading cause of death in acute MI patients, and the literature states anywhere between 38 to 45%. And the pie graph on the right, or on the bottom there, it's the red, and in this figure, it's listed as 38%. It's also to mention the stages of cardiogenic shock, and this is per the Society of Cardiovascular Angiography and Intervention. It goes from stages A through E, with A being at risk and E being an extremis. And in the case I'm about to present, the patients were in the stages D and E. So setting the stage, it's important because it's the most common indication for initiation of ECMO therapy. Some trials that were done previously that were important to mention was the ECMO CS trial in 2022. And this was 117 patients with stage D or E cardiogenic shock. They were randomized and they either got immediate VA ECMO or early conservative therapy. And there were no clinical outcome improvements that were seen in this trial. Some other important trials that were mentioned are the EuroShock trial, and unfortunately, that trial had too limited of a number of recruitment due to the COVID pandemic, so it never showed any statistical significance. However, it did show some survival outcomes that were better in the ECMO group. And then there was a smaller trial, which is one of the first ones that was done in Germany in 2019. And this one showed that 42 patients with cardiogenic complicating acute MI had no benefit from receiving ECMO. The whole basis of this talk was from this recently published trial, the ECLS shock trial. It was published in the New England Journal of Medicine in August of this year. It took 417 patients that were randomized. It's multi-center, open label, and it was done in multiple centers throughout Germany and Slovenia. Some of the inclusion criteria included adults, ages from 18 to 80 years of age, acute MI complicated by cardiogenic shock, as well as they had planned early revascularization by either a PCI or a CABG. Exclusion criteria included like patients who undergone CPR for more than 45 minutes before randomization, mechanical cause of the cardiogenic shock, or they had severe peripheral arterial disease that precluded them from even starting on ECMO. The groups included the ECMO arm versus the control, and then the outcomes that I'm about to go through is the primary, secondary, and the safety outcomes. So for the primary outcomes, the primary outcome in this study was death from any cause within 30 days. There was the ECMO group, which 100 patients had died, and then in the control group, 102, with a relative risk of 0.98. As you can see on the graph there on the left, the orange line is the ECMO group as well as the blue line with the arrow pointing at the 30 days showing no statistical significance between the two. Some secondary outcomes that I want to highlight are the acute renal failure warranting renal replacement therapy. It's 17 in the ECMO arm versus 29. Recurrent MI with both 2 patients in each group, rehospitalization for CHF, which is 3 patients in the ECMO arm versus 2 patients in the control group. Time for hemodynamic stabilization, which both were 3.1 days, and the length of ICU stay was 12 days in the ECMO group and 10 days in the control group. And then some safety outcomes to highlight. It was moderate or severe bleeding with 23.4% in the ECMO group, as you can see on the bar or on the graph up on top in the orange, and 9.6% in the control group, as well as peripheral vascular complications warranting intervention, which is 11% in the ECMO group versus 3.8% in the control group. And then the frequency of stroke or systemic embolization didn't show much difference between the two. So conclusions, discussion within this study itself. What are some possible reasons for the absence of the benefit? It could be device-related complications of the ECMO itself, including more bleeding and peripheral ischemic events, as you saw in the safety outcomes. Can cause worse outcomes in the ECMO arm, as well as the duration of mechanical intervention, ventilation. The patients in the ECMO group were ventilated longer than the ones in the control. And then some limitations of the study. It was not blinded as it was an open trial. And then 39 patients actually crossed over from the control group to the ECMO group as well. And then the other thing was that these studies were done, or trials were done in medium to high volume ECMO centers. So the area or the level of expertise between the ECMO teams could have differed, causing difference in outcomes. So to summarize all of this, ECMO therapy did not reduce the risk of death from any cause at 30 days follow-up in comparison to medical management. Previous trials, including the ECLS cardiogenic shock trial, as well as a small German trial that showed similar findings. Is ECMO the answer in this specific indication? I mean, given the safety outcomes, it seems like and with no mortality benefit, are we doing more than we need to, just because it's available? And so is this myth confirmed, busted, or plausible?
All right. Great. Good job. Anybody have any questions or comments about this topic? Yeah.
How were the crossover patients accounted for statistically?
They were part of the control group still.
So it's based on the intention to treat.
Yeah.
How often have we ever used ECMO here before? I haven't been here that long.
No, we're not an ECMO center. Yeah, I think the closest one is Ventura.
Do you happen to know if they looked at like mortality beyond the 30 days, like 60 or 90 day?
No, unfortunately, there was no like follow-up trials or post ad hoc. But I think, yeah, it wasn't, fortunately, or it was just recently published. So.
Well, I think it's a good example of the fact that technology often advances faster than our knowledge, and I think the reason why I wanted to present this stuff before about the FDA approval process is that we need to understand that devices really don't go through as rigorous a process. So these devices may not necessarily be safe themselves, as well as the technique, which gets widely marketed, sold, and adopted throughout the country and the world even, long before there's really good evidence that the technique itself is even effective. So I think this is a good example of that. We've seen this, some of us in the room that have been around a while have seen this over and over again with different technologies over the years, where things come out, they're new, everybody thinks it's the latest and greatest, and 15 or 20 years after it's been on the market and people have been treated with it, and probably a lot of deaths have occurred sometimes, they finally get around to doing a randomized controlled trial showing that it really doesn't work. So, or it's not really effective. Anyway, that's my thoughts. So what's your thoughts? Is it a myth? ECMO improves survival of cardiogenic shock complicating acute MI. So people think this is true based on the evidence. Still plausible, there's not enough evidence, or busted. Looks like most people are busted, and some people didn't vote. Okay.